So, good evening, everyone. My name is Dr. Robert Horowitz. I want to welcome you to this evening's presentation. We're going to talk about some very interesting topics this evening. We're going to talk about how biologic dentistry can help you in implant dentistry. We're going to look at this through the eyes of a periodontist and how you can affordably and predictably regenerate the bone you need in implant dentistry, replace hopeless teeth, and do all of this at the same time that you are saving yourself money. And let's get into this. So what we're going to look at is some of the types of bone grafts that are available where you are, wherever that is in the world. We're going to look at this. We're going to see how the human body sees these bone grafts. We're going to look at the predictability, primarily of the Dentin graft, which is what we're going to focus on today. See what biologically it can do for you. We're going to see how affordable it can be to incorporate in your daily practice of surgical dentistry and implant dentistry. And we're going to see how applicable this is going to be to the future. So I'm a periodontist. I teach at New York University, primarily in the Department of Oral Surgery these days, but I've taught in periodontics, worked in biomaterials and biomimetics, and I've been exposed to a lot of very bright people, and you're going to hear me talk about some of them today. And on the bottom right side of your screen, you'll see my email address. So if you have any questions, other than the ones that we'll hopefully get to at the end of our presentation today, you will be able to email me there. Unfortunately, due to formatting, switching from my Keynote to PowerPoint, part of the email address got whacked off. So you'll see the com is missing, but rahDDS@gmail.com, that's how you can find me. So let's get started. As a periodontist, if I were one of my own patients, I would want the procedures done to me in the surgical realm to be minimally traumatic. I'd want to have optimal biologic results. I'd want them to work clinically. And as the dentist, I want to make money at the same time. I want volume preservation of bone. I want more keratinized tissue. And I want to know when I place an implant that there's biology behind it, that I know that I'm going to have predictable results. I've used many, many bone grafts over the years, and if you look me up on PubMed, you can see a number of them that I've worked on. We're going to look today at some of the similarities and differences, and if you think about the materials that you've been exposed to over the years, they differ mainly on the source, whether they come from other humans, whether they come from animals, or whether they come from a laboratory. They differ on how much mineral content they have, and whether they are demineralized or mineralized. And then they differ by how they're handled by the bodies. Some of the synthetic materials dissolve. Some of them resorb. Same happens with materials that come from different animals. Some of them don't ever dissolve or resorb. And these may or may not be good scaffolds. Some of the materials that you're going to see today are actually bioactive. And because they have growth factors in them, they actually stimulate new growth of bone. And that's something that as a periodontist, I always want. I always want more bone, more blood supply, and more keratinized tissue. So let's start by looking at bone. What is it? What does it do for us? It actually, in our whole body, it acts as a structural component. It not only holds our jaws together and lets us chew and speak, but it holds us upright. It supports all of our organs, our lungs, our brain, our legs, and brings us from place to place. It also acts as a reserve for calcium. It's vital. It turns over with time, and we see that in our patients who are osteoporotic, and that can be a problem for us. But also when there's stress placed on the bone, it remodels. We have bone deposition, we have bone dissolution. If that doesn't occur properly, again, we can have osteoporosis and other diseases and disorders. So in short, bone is a mineralized organic structure that resorbs and remodels based on the stresses that it undergoes. So think of that when you look at research papers that are done, and if there are bone grafts that are placed that don't have vital bone around them, that don't dissolve or resorb through osteoclastic activity, then how can they resorb and remodel? How can they handle functional stresses? How can they handle stresses placed on an implant through mastication? So let's look at some of the things that we're going to talk about today. In dentistry, if we have a tooth, that's going to undergo stress. And we need around our teeth for those stresses to be taken up by the jaw so that the patient can undergo proper mastication. Same thing around implants. We don't want patients to just chew on that one implant. We want stresses to be noticed and proper proprioception to handle those forces so the patient can chew properly. Same with temporomandibular joint and the whole jawbone itself. We need those forces to be noticed and appropriately disseminated through the structures. And again, the normal bone physiology is a whole cycle: bone formation and resorption. There are reversal lines that we learned about histologically. And then there are resting phases when the bone is in between resorption and formation. So where do we get bone grafts? We can get them from people. We can take them from the same patient, which is called autogenous bone, or we can get them from a patient who is deceased. That's what we call allograft or allogeneic bone. If the graft comes from an animal, it's a xenograft. We normally get those either bovine from cows or porcine from pigs. And if there's a synthetic bone, that's called an alloplast. That can be calcium sulfate, can be beta-tricalcium phosphate, or it can be hydroxyapatite. And as we'll talk about, these grafts are all handled differently, all seen differently by the body, which means they form bone differently, and they're all dissolved or resorbed differently. All of them we can expect to form different amounts of bone, and therefore may handle the way we place implants and the timing for placing implants at different rates. So if we place autogenous bone, if we take it from the mandible, if we take it from the ramus, if we take it from the chin, if we take it from the knee, if we take it from the hip, which most non-oral maxillofacial surgeons try and do, what we do is we can find that autogenous bone, even though the cells die once the blood supply is taken from them, it acts as a scaffold, but it will resorb, as all of the literature shows. So most people, if they want a human type of bone, will go for allograft. That's often taken from a deceased patient. And you can get cortical, or the more dense outer portion of bone, or cancellous. That's the more scaffolded portion. Xenograft, if we get that taken from an animal, depending on whether it's taken from a cow or a pig, it may resorb at different rates. Some of them in the literature have been shown not to resorb at all. So we will talk about that a little bit. And alloplast, the synthetic, if it's hydroxyapatite, doesn't resorb at all. Calcium sulfate resorbs very quickly, and you may lose volume if you use that. Some other alloplasts, tricalcium phosphate, resorb at varying rates. Some newer alloplasts that have sodium and silicon in it may form bone quickly and still preserve, and research is still being done on that. What we're going to look at today primarily is a brand new autograft, which is ground dentin. Because of the ability to get small and large particles, the growth factors that we're going to learn about today that are in that bone graft material can be released at different rates, and the large particles will still hold the volume of that graft during healing. So if we look at the triad of bone formation, we look at the scaffold on the top, and that's what we put into the site, whether that's a blood clot, platelet-rich fibrin, or our graft material. And that's what's going to hold our space. If we look at the bottom left of the screen, that's the cells that are going to come into that space. Osteoblasts are what we want in there. If we're talking about periodontal regeneration, we need cementum and we need fibroblasts. But sometimes to bring in those cells, we need signaling molecules. Something like ground dentin has been shown to have bone morphogenetic protein and other growth factors. That means that the ground dentin is a bioactive graft. It can actually signal to bring in new cells all on its own. So put together, when optimal graft materials are used, you can get bone regeneration, which is ideal. That's when you get your graft particles encased in living vital bone, not in connective tissue. And if we look here, this gives us a very overview, a very brief look at what we want to see in bone formation and resorption. When we have stem cells brought into the site where bone is going to be formed, we would like ideally a combination of osteoclastic resorption of our graft material and osteoblastic formation of new bone on those graft particles. So, questions. Does all bone form at the same rate? And the answer is no. Some patients, and we've all seen this in our own practice, form bone poorly. This can be if they are smokers, if they're diabetic, or if they have different genetic issues. But some sites themselves may not be ideal places to form bone. If we're missing bony walls, if there's been a lot of infection, and the site where we get our precursor cells, our stem cells, where our vasculature is coming from, is further away from the center of our graft, it may take a longer time to get bone formation in the middle. The same thing in the maxillary sinus. It's a generally avascular area. And whether we're bringing bone in from a lateral or crestal approach, this can also take a long time for bone formation. So in these areas where the sites need more help, as I call it, you may want to use a bioactive graft to get the cells in there more quickly. So let's take Tom. Tom is our typical patient. As you can see by the tilting on tooth number 18, the lower left second molar, he never took care of the site where the first molar was extracted. So let's look at some of the problems that he's faced and some of the solutions we come up with. So again, as you see, Tom is typical. Look at the very biggest problem on the bottom. Not just the fact that he doesn't have much time and doesn't have much money, but he has a fear of dentists. And you can see by the gingival inflammation, you can see by the large amalgam restoration that he has not followed through with ideal dentistry. His poor home care has led to his caries rate and his lack of following through. And of course, with the high inferior alveolar nerve, we know that if he loses any bone volume after this extraction, we may not be able to do ideal dentistry and place an implant to replace the missing tooth. So again, we see where the first molar was extracted, we've had site collapse. We've lost alveolar bone height, alveolar bone width, and because of that, we've also lost keratinized tissue, which may limit the ability for him to not only obtain a dental implant in that area, but for him to maintain it. So at 50 years old, we would ideally like to place 1 to 2 implants to replace both missing teeth and not do a 3 or a 4 unit bridge in the site because he has a lot of years to chew. So let's start at the very beginning. How do we remove the tooth and not damage the gingival tissues and not damage the alveolar bone? And that's done by what we call atraumatic extraction. Flapless if possible, and as little fracturing of the buccal or lingual plates as possible. Problems with the tooth are going to cause problems with the extraction. It's multi-rooted. It's most probably non-vital. Because of the large restoration and the flared roots, we have to go very slowly and carefully. So we have to look at the instruments we're going to use and the sequence in which we're going to use them to decrease the chance of fracture, both of the tooth and of the buccal and or lingual plates. So now as you look carefully, you can see the first instrument we use is a high-speed handpiece. The crown is sectioned off before any soft tissue is elevated, so no debris goes under the site. And because we are going to use ground dentin, the first thing that's done even before that is all the amalgam and cement base are removed intraorally. I find that that's a much cleaner and easier procedure to do than to remove any of the restorative materials in my hand. So once the restorations are removed, the crown is sectioned parallel to the occlusal plane, 1 millimeter supragingivally, and then the roots are separated. Once the roots are separated, it's much easier to remove single roots without a lot of luxation towards the buccal, so we can preserve all of the tooth structure to the buccal plates. And now again, all you can see is very minimal elevation of the buccal flap, just so that when it comes time to place our barrier membrane, we have a small space to tuck it in underneath. But to assist in the extraction, depending on the mobility we need to obtain, we can use piezo surgery, we can use periotomes, we can use any of the devices that we need to, just to slightly widen the periodontal ligament space. But again, we try whenever possible to not elevate or to minimally elevate flaps. That's going to decrease blood supply, increase discomfort, increase swelling, increase bleeding, and we want to keep all of that to a minimum for our patient. Next question, do we have to graft? Should every site be grafted, and why? If that's the case, what do we use as grafts and what do we use as barriers? So we look in the literature. There are many, many articles. This one I happen to have been honored and fortunate enough to write with two of my close friends and research partners, Danny Holtzclaw and Paul Rosen, where we reviewed many, many articles on extraction technology and graft materials and barriers. And basically, when you look at all of the articles that are out there, the overall consensus is that when you place a graft and or barrier, you're going to prevent alveolar resorption, both height and width, and you'll have a better chance of an aesthetic fixed bridge, preserving bone volume for a removable partial, and in most cases these days, as we're going for implant placement, you'll be able to get an implant where you need it. So we now have taken all the soft tissue off the tooth. We've removed any debris, any restorative material, and we're placing it in the smart Dentin grinder. Single-use grinder with sharp hammer-like blades, which is going to crush the tooth structure for us. There's a sieve underneath it that's going to get us the ideal particle size, and you'll see what we do. So the smart grinder, we put the tooth in there, we grind it, we sort it into small and large particle sizes. This takes us only about 15 to 30 seconds for this first step. You are going to get plenty of graft material. Some people believe 2 to 3 times the volume of the tooth itself in graft. Once you get the small and large particles, you're going to determine based on how much volume you want to preserve and how quickly you want the growth factors to be released, how much of the small and how much of the large particles you're going to use. Mix the particles together in the sterile Dappen dish that's included with each set of disposable supplies that you get with your smart Dentin grinder, and then you're going to add your pH 11 sterilizing liquid. This liquid is going to sterilize your graft as sterile as if you used gamma radiation or any of the other sterilization materials that are used for by the commercial tissue banks. This process takes a total of 5 minutes, and you now have a fully sterile graft. You now go in and take the very corner of sterile gauze and just adsorb the excess liquid. Now you use the phosphate buffered saline, just wash it twice, literally pour the liquid in, adsorb the extra liquid, takes about 30 seconds. So in a total of 8 minutes from the time you've extracted the tooth, you now have fully sterile processed graft material. You can also treat the tooth with EDTA, which gives you partial demineralization. We know that from restorative techniques that opens the collagen fibers. We also know that from the periodontal literature that it may give us a more exposure of the growth factors that are inside. And we know this from Dr. Schwartz and Dr. Boyan's lab, Dr. Cochran down in San Antonio, that by exposing the inner portions of the tooth with EDTA, we may get more cellular activity and more bone forming activity. So let's go back to Tom. While the graft is being processed, what do? We debride the site. We take our pictures, we take our x-rays. So in the 5 minutes while that graft is being processed, we're not just sitting around, we're getting everything ready. If we need to do any flap manipulation for closure, if we need to trim our barrier, We're doing all of that at the same time, so we're not wasting any of that 5-minute processing time. But now look carefully at the site. You can see on the right side of your screen that very thin buccal plate. You can see where he's already lost buccal height. So if we do not graft, we know we're going to be close to that very high inferior alveolar nerve, and we're not going to have the ability to place an implant. So we always graft to enable ideal dental implant position. And again, we look at the literature, and Henry Greenwell and his group have published numerous studies showing that just by doing grafting, and you can see the literature here, when extraction alone was done in the bottom row, they got almost 35 to 50% by volume loss of the ridge width. So at 6.5 millimeters, if we look at Boozer and Grunder's research, they say we should have 2 millimeters of vital bone on the buccal and lingual of our implant sites. Well, that would be great, except in a premolar, that means you could only place a 2.4 millimeter diameter implant. And where in this same study they did the ridge preservation with a bone graft, they ended up with an 8 millimeter site. And I will tell you, a number of us are doing these same studies, and we're collecting the data now at the Dentin, and we're finding much, much less than 10% site collapse using the Dentin graft. And again, just more literature showing you from other studies that if you do not graft, you can expect to lose 2.5 to 4 to 5 millimeters of alveolar width. So again, conclusion, like from my paper with Dan Holtzclaw and Paul Rosen, if you do not graft, you will lose height and width every time. So again, in this patient, we placed a collagen barrier that was ribose cross-linked and got primary closure because knowing this patient and knowing his fear of dentists and dentistry and knowing his ability to disappear, I wanted to give him the best chance of success. So look at how the graft material itself, even with the amount of tissue we had lost initially, was able to support the height that we wanted to obtain. 1 month shows how beautifully the tissue heals. That's where we started. And again, you can see about a 6 millimeter loss of the buccal tissue in the beginning. And by 2 months, we had gained almost 5 millimeters of that back. So we saw simple atraumatic extraction with a very inexpensive bioactive graft. We got the height we needed, we have the width we need, and now with this patient, just like all the others, we follow on x-ray and wait for bone formation radiographically. So let's take another patient and look very carefully. What do you see here? Yes, we see a premolar that needs to be extracted, but look distally at the first and second molar sites. Look where those teeth were extracted, and look where she had already lost 6 to 7 millimeters of alveolar height. We can't really afford to lose that here, or she may lose contact area. She may get food impaction on the distal of the first premolar. So we want to preserve all of the buccal lingual width. We want to preserve all of the alveolar height possible. So again, like the last patient, to preserve the buccal lingual width of the bone, we first want to do our atraumatic extraction. And then again, we want to do our bioactive graft. We want to place a barrier, and we want to do this as easily as we can for our patient. So again, looking at our atraumatic extraction principles, and this one with my primary research partner, Dr. Ziv Mazur, we're going to look to try and do flapless extraction. Again, like I showed you last time, if it's multi-rooted teeth, we start with sectioning, but when necessary, we go in with piezo surgery, periotomes, and try and prevent the loss of alveolar volume, the loss of keratinized tissue, because we want our implants placed in the ideal prosthetic position so they can support the restoration where they're needed, to stay away from the inferior alveolar nerve, to stay away from the sinus when possible. And again, if we look at Stefan Fickel and his research group, what they show us is if you elevate a flap, you're going to lose even more tissue. So when their study, they used many different treatment approaches, showed that all sites lost bone. When they grafted, they did not use dentin, they used anorganic bovine bone. And they used different barriers than I've used in my studies. They even used a free gingival graft, and they showed that that did not help preserve bone either. So back to Dawn, back to our patient. There's the tooth pre-op. Okay, so Frank, for whatever reason, Frank, so the presentation stopped here, so I'm going to leave it here for a second, and I'm going to start again. So back to our patient. Here's Dawn. Before we start taking out the tooth, temporary crown was placed, and now we're about to start the extraction. So again, you can see on the x-ray, she has non-vital tooth. You can see from the periapical x-ray, you can see where that deep decay is already below the alveolar crest. And to do endodontic therapy, crown lengthening, it was deemed that it would be better off to extract the tooth and graft the site to place a dental implant. Again, to preserve the bone volume, to do an atraumatic surgery, we're doing piezo surgery. We're going to go in just on the mesial and distal, 3 to 5 millimeters, to improve our ability to luxate and loosen that tooth. And as you can see from the overhead view, from looking down at it, no flap elevation was needed at this point to do a full atraumatic extraction. The papillae were elevated, so when we went in with the elevator, we didn't crush them, so we'd have something to suture to. And again, you can see on the x-ray, all the bone was preserved in the extraction. So again, we talked about the fact that we needed to place a graft on our barrier. But when we look for the materials that we're going to use, we want something that we can afford to use, that has been proven clinically, and will give us the biologically advantageous result of giving vital bone with a blood supply so that we can get osseointegration around our implant. So again, when we think about the ideal graft, we want something that, like bone, will resorb and remodel with the stresses placed on it. We want something that can act as a scaffold so that new bone will form around the particles before they resorb. We want something that is affordable for the dentist and the patient, that doesn't have a shelf life issue, that's not going to expire before we can use it, that the body will tolerate well, that's bioactive, and that's available right where you need it when you need it, that you don't have to send somebody in your office running and scurrying for. So we take the tooth. In this case, we're using the piezo surgery device to remove all the soft tissue components. You can use a back action chisel. You can use a high speed with a carbide or a titanium burr. Bottom line, you want to remove any restorative material and any of the soft tissue before you put it in the grinder. Once the tooth is clean, you want to be sure that you have not used a tooth that has any endodontic filling material in it. It doesn't matter if the tooth is infected. It doesn't matter if endodontic treatment was started or if the tooth is infected, because you're going to use a pH 11 cleanser that's going to destroy any non-vital elements that are in there. Sometimes with molar teeth, you have to cut them just to get them to get destroyed and broken down quicker by those hammer type blades. Now you're going to put the tooth into the grinder itself. And again, when you buy the system, you're going to get 6 single-use disposable setups. Each one is going to come with the grinder, the sterile DAP dish, and all the liquids you need to process whether a single tooth extraction or multiple tooth extractions for that one patient. And again, the more teeth you extract on the patient, of course, not that they don't need, but you're going to save more and more money as many teeth as you extract. So the grinder is sterile, it is sharp, it gives you the ability to get, like you saw in the first patient, a sterile, already hydrated graft in 8 minutes. It is autologous hydroxyapatite, but that will resorb and will break down, releasing the bioactive growth factors. And again, the more teeth you extract appropriately in the patient, the more graft material you get and the more money you're saving. So imagine if you have a patient that you're doing an all-on-4 or an all-on-X procedure, you'll get more than enough graft material. So what kind of histologic and biologic effects can we get? Again, we look in the literature. Nampo did an animal study, and he compared iliac crest, which is the gold standard in oral surgery, to dentin graft, to no graft. And he looked at the dentin and he saw TGF-beta, bone morphogenetic protein. He saw growth factors in, bringing all the bone you need. So the smart dentin grinder gives us the ability to get these bioactive graft particles right where we need it, when we need it, shown clinically, shown histologically, and verified in the literature. So we take the tooth from Dawn, we grind it as you saw in the first patient, and the graft material will hold its shape. Again, we elevate just enough, 1 to 2 millimeters of the flap, just to get our barrier tucked in. In this case, this is one of our older cases with a PTFE barrier, but the newer ones we're using the bioactive amnion chorion graft barrier products. Here again, you can see the graft material is holding its shape beautifully, and just a couple of sutures to hold the flap in place over the top. Barriers removed 3 to 4 weeks postoperatively. There you can see the site immediately after grafting. You're packing the material in, not over densely, because you do want the vascular to supply to enter the site. By 10 weeks later, you can see that it's coming, that vital bone is coming in 6 months. You have the height fully preserved. You see the cribriform plates breaking down, and it's starting to look like vital trabecular bone. When we look clinically, we see a thick band of keratinized tissue. We see the alveolar height fully preserved. We see the ideal site for placing a dental implant. As we re-enter the site, again, we see in the middle, we don't see graft particles, which we often see in some of the literature with some of the other either laboratory processed grafts, or we can see in the alloplasts and some of the xenografts, where you'll see some of the particles at the time of reentry. And on the right side, you can see where the osteotomy was performed, the 2 millimeters of vital bone on the buccal and lingual, like Boozer and Grunder have mentioned, that we would like to have. We can see where the implant is placed ideally on the left, and in the middle around the healing abutment, we now see 2 millimeters to 3 millimeters of thick keratinized tissue, which is what Linkevicius says we also need to preserve our vital alveolar bone. And in the right at 3 months, the site is ready to be impressed, and everything is all fully healed. And in the end, we have an implant-supported restoration with vital keratinized tissue around it. So we go from the left with the decayed tooth with the temporary crown on it, to the socket with the atraumatic extraction, to the final restoration with vital keratinized tissue around it. So what did we see? We saw how we can do an atraumatic extraction on either a single or multiple rooted tooth. We saw how simple a graft and barrier placement can be, and we're only looking at a few types of barriers today just due to the short nature of the presentation. And we can see how using a sterile biocompatible graft, which we know from the literature has bioactive components to it, can give us outstanding clinical results. We saw at reentry lack of visible graft particles, which give us volume preservation. But what else do we want to know? We want to know biologically, did we form bone? So we know that we have the height and width we need, but we need to see what the bone density looks like. So let's look on CT scan. When we took out the tooth, and as you can see on the left side of your screen, the alveolar ridge was 8.1 millimeters. When we look on the right at the time of re-entry, 7.9 millimeters. So compare that to my friend Henry Greenwell's study, where they went from 9.2 to 8 millimeters. We lost way less than 10%. We lost only about 2 to 3% of the volume in the width and preserved all of the alveolar height by using the bioactive Dentin graft. So if we want to truly see if we did repair or regeneration, we want to know if we replaced all of the missing volume with vital bone. And regeneration should be your ideal. So to study that, we want to take a sample of the replaced material when we put in the implant. So we're going to use a hollow drill called a trephine and evaluate that bone. If we look at some other studies and we look at anorganic bovine bone mineral to see what some of that research shows, we look histologically and we see that the vast majority in Zviartsy's study from 2001 shows either graft particles or connective tissue in their study. And they saw only at the coronal portion of the graft 17% vital bone and no evidence of resorption at 9 months. What does our material show? Dense bone, minimal connective tissue at 7 months. This is a much more ideal result for placing dental implants. We see ankylosis, or true bone, vital bone linking to the graft particles. So we saw clinically full preservation of the alveolar ridge, keratinized tissue around it with minimal connective tissue and lots of vital bone linking the particles together. And in the middle, you can see a particle of the dentin surrounded by vital bone with a blood vessel right in the middle of it. And that's now 2.5 years post-op with the tissues looking better every day. So we can predictably preserve alveolar volume using the right kind of bone graft. We need to graft, we need to place a barrier, and ideally using the flapless atraumatic extraction techniques that we showed you a little bit of. If we use the right kind of bone graft, if we use the right barriers, we will get vital bone in those sites as well. So what about this patient? You can see in the middle, in the site of the first molar, you can see residual alveolar graft. This is one of the synthetic grafts that I was doing research on. Unfortunately, as you'll see when we do the reentry, not only do we see here in the x-ray where the particles are left at 6 months, but we also see a significant loss of alveolar height. Now, this patient may be a poor bone former. We see she has poor plaque control by the amount of decay on the adjacent teeth. But let's look more closely. We see in the grafted site a loss of alveolar width and alveolar height in addition to the inflammation that she has. And again, you can see on the right side of your screen how much alveolar width has been lost and the concomitant loss of keratinized tissue at the same time. So we know we want to try and use a bioactive material when we go in to graft site number 31. And again, look at the first molar site. Look at the amount of alveolar width that's been lost. Look at the amount of alveolar height that we lost both clinically and on x-ray. And you can still see the graft particles present even at 6 months. So to me, to answer the last question down there, yes, we have room for an implant, but that graft was not an ideal success. So we do our normal implant placement. We take our check film, and we look to see exactly as we know where we need the implant based on our inferior alveolar nerve position and our prosthetic orientation. We get our implant in, and now we get ready to do our atraumatic extraction of tooth number 31. We're going to again use piezo surgery if we need it, our periotomes, and atraumatically extract. So we do minimal removal of bone structure and minimal damage to the bone. But even look on this view. Look at how thin the alveolar ridge width is on the grafted site of 30, the first molar, compared to the second molar. And I want you to particularly remember this when we do our re-entry to place the implant in the second molar site. So now when we're going to graft this site, we're going to want to be sure to use a bioactive graft to give us our best chance of preservation of the alveolar bone width. So when we graft, we want to be sure, and again, this is a schematic from the paper that Paul Rosen and Danny Holtzclaw and I wrote, that we want to be able to use a graft that's going to give us the ability to get vital bone conversion. We don't want to use repair. We don't want to just stick something in the site that's going to fill the space, but we want to regenerate so we can get vital bone. We want to use biocompatible and bioactive when we can, and we saw bioactive histologically in the last patient. We know from the last patient that we can, with the ground dentin, maintain the volume with resorption of the graft and have maximum vital bone formation with minimal amount of particles left. So the ideal graft material, to me, in this case, is going to be ground dentin. The tooth does not have an endodontic filling. We know clinically and in the literature we have the ability to get vital bone and preserve alveolar ridge width. And we know that both in the short period of time and in the long period of time, we'll be able to both form bone and have that bone remodel slowly and the scaffold remodel slowly, giving us the ability to keep this volume of bone and maintain our osseointegration over time. So again, in a patient like this, when we do not have an endodontically treated tooth, what do we have? We have dentin. We have autogenous hydroxyapatite that is easily processed, that we can make sterile when we need it, that is going to be affordable. We will get all the graft material we need for this site right at the time we need it. And if she didn't need it now, if we were taking out extra teeth, we could give the patient that tooth or the extra teeth to hold on to. And then we could process them in the future to use as a graft in another time. So the tooth is taken out, soft tissues are removed. Again, we showed you before with a hand instrument. We showed you with piezo surgery. This is how you can remove it with a handpiece. The tooth is processed again, as you saw, in a sterile chamber, single use. You do not reuse the chemicals. You do not reuse the grinding chamber. I can't stress that enough. You get more than enough for your money with these single-use chambers. You have the sieve to get different particle size. And again, the manufacturer has solved all these issues. You get what you need. So the tooth is put in the chamber, it's crushed, you get the small and large particles, which will give you, as Nampo showed in their study, bioactive hydroxyapatite. Marshall Urist in 1965 showed we get bone morphogenetic protein from these teeth. So we get autologous hydroxyapatite with growth factors, bioactive graft in small and large particles that is sterile. So we're going to add our cleanser. Cleanser is going to be there for 5 minutes. It's going to open up the dental tubules, give us the full mineral structure we need, and not affect the organic matrix, which means it's not going to affect the growth factors. And again, as I showed you before, after 5 minutes with the pH cleanser, we're going to remove the cleanser. Dr. Nelson Pinto down in Chile has showed us that using this dentin cleanser from KometaBio, you get the same sterility that you would from gamma irradiation. The difference is the dentin cleanser from KometaBio does not destroy the growth factors. So we have our bioactive graft. Then again, 2 cycles with the phosphate buffered saline, the liquid is absorbed. So again, in 8 minutes, you have your tooth cleaned, particles, fabric particles prepared, sterile, bioactive graft. And in that 8-minute time period, you're debriding your socket. You're preparing your flaps if you need to, taking your x-ray of your socket, doing everything you need. So what do we have? Instead of just a biocompatible material, something that's sterile that just fills the space, we have something that's bioactive. We have something that the macrophages, the M1 macrophages, can be converted to M2, go from destroying inflammation and infection to actually forming bone. You have the cells turned on to form bone in the socket. And again, you're going to be processing and working the whole time that graft is fabricated. And look how well that material will stay in sight. You put your graft material in the area and you can mix it now with anything you want. If you need more volume, you can mix it with allograft or calcium sulfate. You can hydrate it in platelet-rich fibrin or just leave it wetted in the phosphate buffered saline that you've just prepared it in. And then cover it with your barrier and suture. And then let it heal. 3 months to 6 months, you're going to follow it on x-ray. And then you're going to wait for the bone remodeling to occur. 3 months, 6 months, over years it can remodel without losing volume. Look what we get at 6 months. Look at how little inflammation is, how we have the full ridge width, full ridge height preserved back there. Now look at the difference between the two sites. In the anterior, you have a 4mm implant with a 4.8mm collar. In the posterior, you have a 6mm implant that has 2 millimeters of bone on either side. So you can see how we have much more width and height preserved with the dentin than in this case with the synthetic graft that was used in the anterior site. 4 months from placement, an impression was taken and loading. You can see we have much better keratinized tissue around the posterior implant and on the left side of your screen. And if you look on the right side of the screen, we have much better emergence profile, much better for your prosthodontic considerations, and especially for a patient like this who has less than adequate home care, much better for the long-term maintenance and success of our implant. So what's around our implant? Look on the left side of your screen where we see on the CT scan where already by the time of loading, we've lost height and width of bone down to 6 millimeters at the crest. And look on the right side, we have almost 10 millimeters on the dentin graft. So where the alloplast was used in this patient, we lost height and width of bone. And where the dentin was used, we lost nothing. And then again, you can see the final prosthesis. Much less inflammation around our dentin graft. Better keratinized tissue, better emergence profile on your restoration. And here's the proof. Vital alveolar bone. You can see the dentin particles. Those are the ones that have the little areas of black in them. Those are the cross-sectional cuts of the tubules. You can see here, you can see blood vessels. You can see the dentin particles, and you can see ankylosis, vital bone around those particles. So looking at other articles, again, another of Horowitz studies. On the left is when the anorganic bovine bone mineral was placed. At the right, at the time of reentry, you can still see the graft particles 9 months later. In our studies, histologically, you don't see the particles as much. You see resorption of them. Clinically, you don't see them when you look for them. Again, histologically in Horowitz study on the right, radiographically on the left, you can still see the graft particles. My concern is if you see the particles histologically, you have the possibility that that may interfere with osseointegration. And a patient like Pam, who is a poor healer, I want the maximum amount of bone to implant contact, the maximum amount of osseointegration that I can get. So what they concluded is that their graft with the anorganic bovine bone mineral was non-resorbable. I want a graft that's going to be resorbed. I want a graft that's going to give me the maximum bone to implant contact that I can get. So as you can see from a close-up view of histology from my patient, I was able to control the site. I was able to improve bone to implant contact, get a better bone volume. So as the surgeon, by doing atraumatic extraction, you're going to decrease your loss of bone height and width by using bioactive grafts, bioactive barriers when you can, whether it's the amnion chorion or some other barriers. By hydrating your graft in platelet-rich fibrin, you can even increase your success rate further. So by being the surgeon, you can determine your rate of success and increase it even further. So in your paths, continue to learn. Find mentors, find friends, and enjoy what you're doing in dentistry. You're going to find it is a very rewarding path to be on. So as we're ending the presentation, I want to thank KometaBio not only for coming up with this amazing product, but for sponsoring this webinar. And I want to also thank the outstanding team behind this webinar for putting together a great presentation. Here's just a list of some sites that you can go to get further information for some research studies and information that will give you instructional videos. And again, my email address, if you have further questions, is rahDDS@gmail.com. So during this webinar, I was just sent some questions, and I'm going to answer those for you. So, first question. First dentist is asking, I'm using synthetic grafts in my practice. I think they work. Why should I switch to Dentin grafts? Well, if you look me up on PubMed, you will find that I've done research on many of the synthetic grafts out there, and I can continue to do research on synthetic and other types of graft materials. There are differences, as I mentioned earlier, between the synthetic grafts, how they're fabricated, and therefore how they act as scaffolds and how they're resorbed in the body. Dr. Mazur and I have done research and published on a number of these, including biphasic calcium sulfate, tricalcium phosphate, and more. The biggest difference between ground dentin and the synthetic grafts is that the ground dentin is bioactive. It contains growth factors like TGF-beta and bone morphogenetic protein. Also, if you're extracting more than one tooth, that is, you can obtain significant quantities of graft material using the dentin grinder for the same price. Lastly, and I know this is not scientific, patients think it's really cool to get new bone from themselves and from their own tooth. Okay, next. How long does it take to process these teeth that you are taking out? Again, I've mentioned it in the presentation. It's about 8 minutes from the time the tooth is removed before the graft material is fully sterile and hydrated and ready to go. And again, in that time frame, you can debride your socket. You can take your post-op x-ray of the socket itself, and you can start giving your patients instructions. You can also give your staff a little bit of chance to clean up and get rid of some of the materials. But again, in that 8 minutes, instead of just opening a vial of graft material, you can explain to your patients that you're using this time to give them the processing of bioactive bone grafts. Okay, next question. I haven't seen any graft that is really predictable. Why do you say that this one is again? So if you look at the literature on the KometaBio site and on their Facebook posts, and if you look at my literature and that of some of the other authors and researchers who are doing research on this material, you can see clinical preservation, as I showed, of alveolar bone volume, enhancement of keratinized tissue, and formation of significant amounts of vital bone in a relatively short time frame. You don't see as much of this even in poor quality patients like the last one that I showed you with all of the graft materials are out there. Next question, can dentin graft be used for periodontal defects? What about sinus lifts? So Answer: if you're extracting a tooth and have to treat adjacent teeth at the same time, you can use the graft obtained by grinding that tooth as a periodontal bone graft. And I actually showed that in the last case I presented at the Academy of Perio meeting just last week. You can also save that tooth for use at a future date for sinus grafting, whether it's lateral or crestal. The question is, do you have that site to treat at the same time? Otherwise, you have to have the patient save either the processed graft or the tooth itself to graft later on. Next question, and this always comes up, and it's about cost. What is the price of the Smart Dentin grinder product that you showed? So depending on where you are, it's generally around $1,600 to buy the grinder itself and the first 6 sets of disposables. So the disposable, again, is the grinder itself with all of the liquids you need, and you get 6 sets of those. Now, once you go through those first 6 sets, so if you look at that as $250 per case for the first 6 cases, from then on, every case you do, and you'll buy 6 sets of disposables at a time, it's only $50 a case. Forgetting autologous graft material that's bioactive. So it really is very affordable, especially considering that you can often get 2 to 3 times the volume of graft material per volume of the tooth that you extract. And if you're doing an all-on-4 and all-on-6, you're going to get so much volume of graft material that you can overgraft the whole arch. Next question, can the tooth or remaining graft be saved for future use? Do you have to use it immediately? So there are 2 ways to save the graft for future use. If you're extracting multiple teeth, you can grind and process some of the teeth and give the patient the rest to save for use as a later date. Just give it to them in an autoclave envelope and have them bring it back when you need more grafting at a later date. That's one way. The second way is you can grind and sterilize all the graft and then take some of the graft out of the sterile Dappen dish to use today and then give the patient the rest of that material to bring home. If you're going to use the rest of that graft at a later date, you need to re-sterilize it with the Dentin cleanser and then rebuffer it with the phosphate buffered saline solution before you use it the next time. Last question. Does the graft work with platelet-rich fibrin? Dr. Mazur, Pinter, and myself and others have all shown clinical cases with histologic results of using this material, either hydrated in the liquid from LPRF or even made into LPRF blocks. In this short a presentation, there's not enough time to show you all the multiple applications. Either grafts or, like I said, the new bioactive amnion chorion barriers that we're using for the new cases that we're using, both for periodontal and ridge augmentation defects. So for more information, look at Dr. Pinto's research, mine, Dr. Mazur's, Dr. Snezana Pol, and others who are using this in multiple indications. Look us up on PubMed and look for us when any of us are speaking in your neighborhood. So if there are no other questions, I again want to thank our sponsor, KometaBio. The outstanding technology that went into development of this product. And I want to thank the technical team that's behind the webinar for all the outstanding effort they've put into it. So thank you and have a wonderful evening, and I look forward to seeing you when I'm in your neighborhood. So I thought when the phone rang that it was you and not my patient.
Yeah, no worries.
So literally, I thought it was you telling me to share my screen. Right. Yeah, for whatever reason, it just froze there. That's why I went back to it and whatever.
No, you did. That was perfect. Exactly what you do. So it makes my job easier. Editing.
Yeah, as you can tell, ain't my first rodeo.
Yeah, no, that was great. Audio was great. Sailing was yeah, no, it's fine. I'll be
And it looks to me like it was like just under an hour, like 58, 50 whatever minutes. So, all right. And if there's any other questions, anything you need, holler. Thank you. Go home. Thank you. All right, you too. Bye.